I'm here with Dr. BUINEWICZ, and we're over in Flemington, New Jersey at his office. He also has an office in Doylestown, PA. He's better known as Dr. B to those of us that adore him. He was my surgeon. He did my explant May of 2018, and he's allowed me to sit with him today and ask him some questions so that we can better educate everybody out there. So thank you so much for sitting with me.
Thank
I
you
really
for asking me to
appreciate
do
it.
this.
Absolutely. So I just want everybody to know a little bit about you. How long have you been practicing plastic surgery?
I finished my plastic surgery residency in 1992, so it's been 27 years, believe it or not.
Okay.
It goes fast.
Yeah, it sure does. And I guess my first question is, in your education, was there ever any mention of adverse reactions to breast implants that you were told?
Yeah, I was very lucky in a way, because my residency started was in 1992, and that was when the implants were first pulled off the market initially back then. So no education at that point in time. All of us were, as residents, as the plastic surgeons I knew, trying to get as much data as we had. I mean, the difference back then, we had no access to the internet.
Right.
You wanted to find something out or research something, you had to go to a library, do a literature search, pull articles, try to find those things. So there was data out there. There was definitely published data and theories about potential silicone toxicity, reaction to silicone and implants, but there wasn't any good controlled studies, larger population studies at that time.
Right.
Most of them were case reports, small case studies, and people just took them for what they were worth, which was a case report. Nobody started to do anything larger study-wise.
Right, okay. Yeah, it's not like now when social media, everything, internet, everything's at your fingertips.
It's instantaneous now, correct?
Yeah, absolutely. Okay, so how did you personally become to believe in breast implant illness?
There was always a question from my time in residency, knowing about the issues with silicone when they pulled them off the market. Being a surgeon and through the years as, treating patients reconstructive, cosmetic reasons and all, nothing is ever perfect. Mm-hmm. And you always had complications, issues with implants. You tend to see them more in reconstruction patients because there's less of their body that's covering the implant. It tends to hide imperfections and all, but people always have problems, either pain, discomfort, malposition. We get the rare infections, but they were never quite perfect.
Okay.
The first breast implant illness was one of my patients who had came back in probably a good 10, 12 years after having saline implants in. Children, life had changed, and wanted her implants out, and I asked her why. She was telling me she was not feeling right, and there was this Facebook site, breast implant illness, and she was the start. I agreed to take her implants out. She wanted the capsules out. We talked about it. It made sense logically, so I did.
Yeah.
And she was the first one, and she's got better quickly.
I think I know who that is, and she still belongs to our group.
I'm sure she does, but
yes.
yeah. I don't see her that often anymore, but no, she did. She was the first.
She's living life, so she's
good.
So how many explants have you done now?
We are in the process of putting all our data together. We are waiting for our final IRB approval to be able to publish a paper. More importantly, send prospective questionnaires out to the patients I've taken care of. But the numbers we looked at were over 300 explants and capsulectomies.
Okay.
Average follow-up is probably going to be at least a good 8-9 months now. So a lot.
Yeah, great.
Sadly, but a lot.
I know, yes, but we appreciate what you are doing because you're saving thousands of women.
Thank you.
How many explants versus implants are you doing now?
Maybe, I'm trying to think in a week. So we do 16, probably about a 1 to 10 ratio, 1 in to 10 out.
Okay, wow.
Yeah.
All right, that's great. So
at the most. I mean, in the interest, not to interrupt you.
No, that's okay.
And it's like, how do you continue to educate people but not scare them?
Yes.
I tell everybody about, anaplastic large cell lymphoma. A lot of people doesn't quite affect them as much. I tell them more breast implant illness. Mm-hmm. That one tends to raise a little bit more of an eyebrow. The thing which gets everybody and will tend to turn them off is that I tell them they're temporary. This is a temporary operation. You're going to need to do something, especially the young ones, at least one more operation in your lifetime to fix a complication from the implant, take it out, or do something.
Right.
That temporary nature where they're going to need to do something else, that's what tends to get people.
Yeah, because I was told they were lifetime devices by my first surgeon.
Not anymore, no.
Yeah. So yeah, that was actually my one question was, what do you tell women who come in for an augmentation? So it's great that you're educating them, and yeah, that's wonderful. Do you foresee yourself ever not doing breast augmentations?
I think it's going to be a natural progression anyway of the whole process. I mean, again, just like society, you know, large breasts, big breasts are not fashionable anymore.
Right.
Nowadays, everybody wants a big rear end. But
yeah.
but big breasts or not, people are more wanting to be natural or at the most lifted. I mean, there are definitely situations like a breast cancer reconstruction or somebody, you know, congenitally one breast didn't form and the other
right.
one where, you know, those patients, you know, an implant is an option. We don't have a lot of good valid options that are not significantly invasive operations yet.
Right.
You know, fat grafting looks promising, but there are potential issues with fat grafting too.
Right. Okay. So, top 5 breast implant illness symptoms that you see. Would there be a top couple of symptoms?
Brain fog, fatigue, brain fog and memory loss go in there.
Mm-hmm.
The joint pains, muscle aches are probably one of the most common ones that we tend to see. GI issues for sure. Probably after that, I would say more skin-related issues, either hair loss, acne, rashes.
Yeah. Yeah.
But I mean, we see everything. Every day there is a new symptom that we even thought of.
Right.
People come back post-op with things that have gotten better that you wouldn't even, like palpitations.
Right.
That you wouldn't expect would get better taking an implant out, but they do.
Yeah, absolutely.
So the list keeps growing.
Yep, I had all those symptoms that you talked about. So, are you seeing many of the same autoimmune diseases in women? Like, I know a lot of the women talk about lupus and Lyme's disease. Are you seeing a lot of those?
I don't see a lot of people that are truly seropositive, tested positive for like a Lyme's or rheumatoid arthritis. Most people that I see, and again, we'll be able to clarify this with our data, most people are like 9 steps close to having rheumatoid arthritis, but don't get the final definitive, you know, seropositive test like Lyme's disease.
Right.
So they know they have an unknown inflammatory arthritic condition, but they can't specify it.
Okay, yeah. Do you see any comorbidities with breast implant illness? So anything that would make them predisposed to, because I guess a lot of us are trying to figure out.
Why? Who's at risk?
Right, right. Are we at risk if we're...
No, and I've been much more specific at asking. That's one of the reasons I want to do a questionnaire to send out to patients. So the whole part of this study is, everything is retrospective based on what the patient writes down on their initial intake form, what I write note-wise and put in notes, what I think is important. It'd be interesting when, you know, I can compare what that retrospective part of the study does, but then to send out a prospective questionnaire, here's all the symptoms, rate what you had pre-op, rate what you got now, where you're at, and see what really is out there.
Right, okay, that's great. So let's talk about mastectomy patients. The ladies wanted to know if, well, first of all, what is your experience with explanting women post-mastectomy? You've done a few, or?
You see more and more.
Yeah.
And I think it's because of knowledge, because, you know, it's just not, people are thinking breast implant illness and augmentations.
Yeah.
They're not thinking cancer and reconstruction. The women with cancer and reconstruction are becoming much more informed and are aware of it. So we're seeing more and more. Interestingly, almost like what I saw with breast implant illness when I started, you know, initially there were some really sick women and disasters no matter what I did or anybody else probably could have done, they weren't going to get better. You know, the damage was already done, and you couldn't really help them at all.
Yeah.
Sort of saw that with the reconstructions at the beginning too. Some people had, some disasters from their reconstruction, multiple operations that, got somewhat better or very slow. Now I'm seeing the opposite. I'm seeing people, 1 or 2 complications into their implants that are aware of breast implant illness. They're now definitely aware of the lymphoma issues, saying like, get them out.
Get them out.
It didn't work. It's okay to be flat. This failed. I'm going to live this way until something better comes along.
As long as I have my health.
Exactly.
Yeah, because I know I've heard a lot of women. I justified all my symptoms as I was tired mom, bodybuilding, whatever. A lot of the post-mastectomy patients are blaming things on their chemo and their treatment that they had.
The hormonal therapy treatments that they're on, everything.
Right, and
radiation.
So then they don't make that correlation.
Correct.
Yeah.
Because they're inflammatory symptoms.
Right.
And inflammation goes along with any disease process, or most of them.
Yeah. Okay, so you just covered the next question. And do you perform fat transfer surgeries?
I do.
You do?
I
okay.
do.
And who who do you normally recommend those for? Like, what are the criteria that they'd be a good candidate?
I mean, fat like, fillers for filling in a wrinkle, I mean, it's volume. So where somebody has a volume loss, you put volume back in.
Mm-hmm.
Fat was meant to be transferred, and the FDA has gotten, they're going to be very, very controlling of this, and rightfully so. Fat should go back as a soft tissue filler where there's fat.
Right.
So the plastic surgery societies with reconstruction patients, I mean, if you've technically removed all the breast because of the mastectomy, there's no breast there anymore, it's basically skin and fat. To put fat into a reconstructed area, safe thing to do. Or
Okay.
should be safe, it really shouldn't be an issue with it.
Right.
The issues are gonna arise in when you're putting fat into a breast or near a breast.
Okay.
So, I mean, when I do fat grafting, I mean, the fat's gonna go under the skin, above the breast tissue, or if I had to, deep under the breast, on the underside of the breast tissue, or even in the pectoralis muscle.
Okay.
I would not inject fat into the breast because, number one, we don't know what's gonna happen if you put fat into the breast.
Mm-hmm.
And, if it doesn't heal well, if it calcifies or forms a cyst, it can throw off a mammogram, then you get a whole nother problem.
Right, okay. And I imagine that the patient would need a certain amount of fat on her to
Correct.
take from, right?
Correct.
Where do you normally take the fat from?
Two most common places, belly, lower belly, inner
Mhm.
thighs. Those are
Okay.
usually the two best areas to get fat. They have the highest survival rates.
Okay. All right, so let's talk explant surgery a little. Why is it so important to remove all the capsule?
That is one of the big hot topics from my standpoint. I mean, just again, it logically makes sense. That's your body's, interface connection between you and the implant. Number one, it's where the lymphomas form.
Yeah.
So, I mean, if somebody has a textured implant in, from my standpoint, I would absolutely want to get all of their capsule out of them for sure.
Mm-hmm.
And the same thing too, I mean, if you take a step back from, enough inflammation to cause a cancer, moderate amount of inflammation that may be making somebody sick, get away the inflammatory surface.
Right. There's a lot of surgeons out there that will say your body will absorb it. Don't worry, your body will absorb it.
Sometimes if you have normal pristine scar tissue, yeah, it'll go back to normal tissue. Basically, it's called loose areolar tissue, but it's sort of flimsy connective tissue.
Mm-hmm.
But if you have a contaminated implant, bacteria, fungus, or whatever, something's up, that capsule doesn't go away.
Right, and you don't know if it's contaminated
Correct.
until it's out, so.
And we see it all the time when people that have like belly surgery, you go back in, you find incidental seromas or fluid pockets, and you can find those capsules in there, so.
Yeah, so you need to get them out.
Especially in this, yes.
Yeah.
For sure.
En bloc versus total capsulectomy.
They're both the same.
Okay, so.
One is en bloc is getting the capsule out in one piece.
Mm-hmm.
Total capsulectomy, you're getting it out, but there's probably rips or tears.
Mm-hmm.
In total capsulectomy, most of mine will come out in a sheet. So you can lay them out,
Yeah.
even though there's strips and cuts from tearing it while I'm taking it out, but it comes out in a sheet. Occasionally you'll see people where you take it out in pieces because it's so inflamed.
Right.
But en bloc goes back to a cancer terminology where you are taking normal tissue to make sure that you don't get close to a cancer.
Right.
And not, spreading cancers.
How do you know which to do?
I mean, this is not a cancerous process, breast implant illness. I mean, there hasn't been anybody I know of that's developed a cancer from that so far.
Mm-hmm.
So, I mean, I would not be ultra aggressive at basically doing a mastectomy, sacrificing normal tissue
Right.
to get the capsule out of
Right.
somebody. If I suspected a lymphoma, we should have enough suspicion ahead of time that we know that's what we're dealing with. That's the patient you want to make sure you try to do an en bloc.
Okay.
And even with that, I mean, if they have, like we just talked about, if they have thin capsules, you may not be able to.
Right. Right. Yeah, I have heard that because most surgeons, even if they do en bloc, most of the time they say, I can't guarantee it.
Correct.
Because you don't know what you're going to find when you
You
get
don't. That's
there.
why I don't tell any of my patients. I would never
Yeah.
promise an en bloc or guarantee it because you don't know until you're inside.
Right. It's been said many times that you are very good at deciding if a woman should get a lift or not a lift. So, to lift or not to lift, how do you decide who needs one and who?
Person by person.
Okay,
It's
so
really
individualized.
hard to gauge and judge. You have to sort of take a little bit of a risk with that.
Yeah.
But I mean, it's just years of what I've been doing.
Right.
And more importantly, people have breast implant illness syndrome, they're sick. Do one thing, get your implants and capsules out, get better. You can always go back and pick up the pieces and do a lift if you do need one afterwards.
Right.
The less you do, the better usually.
Health first, like we keep saying, right?
Yes.
So, as far as healing, are you seeing your patients healing after
They do.
explant?
Amazingly so, conservatively 80-90% of people are getting better, significantly better from having their implants and their capsules out. Interestingly, I don't have a good explanation besides just the inflammatory response, which is probably going on, is that they're getting better quickly.
Yeah.
You know, within a week or two, people are seeing their symptoms starting to go away.
Mm-hmm. And you see flares. People get flares.
And
Yeah.
I mean, and just you see people that will continue to have flares. You know, months down the line, you have definitely other people that are fine for a month or two, and then start going back the way they were, and then start bouncing back again. I mean, it's expected. I mean, for an operation of that magnitude, minimum of 6 weeks recovery time just from that alone.
Just from the surgery
Correct.
alone, right? I know, because so many women want to heal right the moment they are done from surgery, and we try to remind them you have to heal from the surgery first,
Yep.
and then worry about the breast implant healing.
Absolutely.
Yeah. Have you ever had a patient who had breast implant illness, had an explant done, and was so unhappy with the way they looked, they came back for implants again?
One patient.
You had one patient?
We've
Okay.
had one patient, and
I wasn't expecting that.
we have had one patient that had her implants out, fairly deformed afterwards. I mean,
Okay.
was going to need something,
Mhm.
you know, and unfortunately, it was a big part of her body image was her breasts, her appearance, the way that she looked.
Mhm.
So she waited a full 6 months, fully recovered from her symptoms, went back in, put in the new ideal silicone baffled implant, the saline baffled implants.
Okay.
That are supposed to feel more natural.
Okay.
Got twice as bad. Went back and took her implants out again. She's been explanted twice by me.
Okay.
So yeah, one patient
That took a
again
turn I wasn't expecting.
does not make a series, but yeah.
Wow.
And
Okay.
she is very vocal about the mistakes that she made. And again, I mean, it's you know, it's everybody's body. It's your own personal
Yes.
choice, and you know, I tell everybody, you know, if you're not happy, it's a reversible operation. You can always put one back in. She unfortunately did it and got much worse,
Okay. Wow.
and is now recovering again. So it's
Yes.
really very interesting.
Okay. That's okay. I wasn't expecting that. Thank you. I'm so
Mhm.
glad I asked that. So one of the ladies wanted to know if you've ever considered partnering with someone who can assist with the healing and detox part for ladies. So having someone here in the office
If I could
available.
find
to
somebody, it would be because it is
Yeah.
a process.
It is. Yeah.
It's just
and-
not. It's definitely just not taking implants and capsules out.
No.
That's a big part, but it's not everything by far.
Yeah, and I know that you're really good at following up with ladies and trying to make sure that, you know, seeing how they're feeling and what symptoms have gone and what are, you know, what's still remaining. And so I think having somebody
It would be a good
be
approach.
like one-stop
Definitely.
shopping for us as
Definitely,
women.
definitely.
Yeah, someplace that we could go
But
for
again,
a
too,
whole.
like what you guys have been through, I mean, it's hard to find somebody that you can trust.
Yes, that really
And, you know,
understands.
there will be some people out there that are going to take advantage of the situation by far.
Yeah.
And I'm sure you guys see
Yes.
it now.
Yes, we do. Yes, we're very cautious of who we allow to give advice and
Mhm.
detox advice. Detoxing it's so individualized.
Correct.
And it's so sensitive that you have to be careful. So I can understand why you need to find somebody that you
Mhm.
really trust. So I know you mentioned earlier, are you able to share if you're doing any publications in regards to breast implant illness?
We are waiting for IRB, the approval. So we started this basic, I'm looking at the data to try to organize it, but once we get that approval, I will be able to officially, you know, get the retrospective data published, we'll be able to get a questionnaire out.
Right, that's awesome. A touchy subject for a lot of the women is the financial aspect of it. So, insurance, can you speak on what your experience has been in trying to work with insurance as far as explant, and if you have any
They are-
advice for women who are trying to get it approved?
It's the most important thing. Unfortunately, breast implant illness does not have a diagnosis
Right.
code.
We're
So
working on
that's a
that.
bit. Even when you do, the insurance companies are probably going to say, you know, we're not paying for it. You put these in for cosmetic reasons or whatever. So first step is getting it recognized as a disease process, and so
Yeah.
you can give it a diagnosis code. There are definitely other symptoms and issues that people have. You know, breast pain. You know, complications with the implants. There are codes out there.
Mhm.
The insurance companies have gotten horrible. You
Yeah.
know, I'm very particular, careful with my documentation of symptoms. The people have been to doctors, have had full workups. I mean, everybody's got their records and all, but
Right.
it's like pulling hair with the insurance companies.
Yeah, it's
They
awful.
are denying now, Horizon Blue Cross New Jersey are denying confirmed ruptured silicone implants in an augmentation patient because they put them in for cosmetic reasons.
That's
Absolutely no, saying we are not paying for it. Reconstruction patients we're having issues with
That's
now.
what I was gonna ask.
Absolutely, fat grafting, where they're denying fat grafting, it's gotten very bad.
Wow, that is a shame.
Medicaid puts, I think, a 5 or 7 year time limit on reconstruction. You know, if you have Medicaid and, you know, God forbid you have a complication,
Mhm.
chemotherapy, whatever, you may miss that window.
Wow.
and not be allowed to reconstruct. So it's getting worse, not better.
That's such a shame.
It really is.
Okay, we're gonna wrap up a little bit, but I just wanted to have you talk about the recall. So in the last week, this was a huge recall from Allergan with the textured implants, and I just want to let you talk about your thoughts on that.
Yeah, I mean, it needed to be done, the recall. I mean, I believe so. I mean, there's enough, there's enough of a smoking gun out there, put it that way. Reading through what the FDA has released as far as their reasons and reports, what I can find is they were able to identify in 13 patients exactly what implants were in them and confirm it. 12 of those 13s were the Allergan BIA-ALCL textureds. That's when the FDA said, okay, you need to pull these off the market. We're asking for a voluntary recall. Fortunately, Allergan did.
Right.
The other thing that they could do is they could do a black box warning.
Yes.
And just say, okay, this is like a pack of cigarettes. You can
Yes.
have your implants, but you're taking a risk here. Here's the risks.
That's one of the things that we were requesting when we went to the FDA in March.
Yeah, I mean, and the biggest thing is, nobody knows, nobody's addressed what to do with the capsules.
Yeah.
And the capsules, it's not taking the implant out necessarily. We don't know if taking the implant out is going to reduce the risk of getting lymphoma, take it to zero, how long that lymphoma takes to form. So
Yeah,
nobody's addressing that, and it frightens me to think that women are going to think that, oh, I'll get my implant out, put a new one back in, I'm going to be fine.
Right, and that they're not pushing, you have to have the
Correct.
proper
From what I
explant.
understand, I mean, there are some case reports in that ALCL group that had originally a textured implant, had switched out to smooths, still wound up getting a lymphoma.
Yes, you are correct.
So, yeah, I mean, the capsule has to be addressed.
Yes.
So,
Well,
I mean,
we're all
it's a
working on
step,
it.
it's a step in the,
Yes.
right, it's a recognition, but there's still a long way to go.
Yeah, do you think that Sancho Mentor will follow along?
They are different processes significantly different processes from what I know to make their
texture.
texturing.
Mhm.
They are trying, it looks like they're trying to, distance themselves from Allergan.
Yeah.
They're not thinking of doing it. They're going to try to, I think, as an industry, keep their part of the market.
Right.
But for what it's worth.
Yeah. Well, hopefully we'll
The,
continue to see changes.
Yeah, I know for the people out there that do have lymphoma, the Plastic Surgery Society, the American Society of Aesthetic Plastic Surgeons, I think ASAP's combined with them. There is a fund. So if somebody doesn't have the money and, thinks they have ALCL or gets ALCL,
Mhm.
the societies have put money aside to help people pay for treatment. So
Okay. Do you know how people can?
it should be on my web, on the new breast implant illness page I did.
All right.
I
Maybe
think there was a link at the bottom. If not, I'll send it to you.
All right. Yeah. Send me the link and we'll post it here
Yeah.
so that everybody can
Yeah.
get to that, because that would be
It's huge.
That
Yeah.
would be amazing. All right, so anybody who's watching the video who has implants, who's scared to explant, do you have any advice for them?
Call me. Just talk to somebody you trust.
Yes.
Put it that way.
Yes. Okay. Well, listen, you saved my life.
Thank you.
And you are
It was
saving
my pleasure.
hundreds of other women. And the fact that you're so open and that you post these things on social media and you're not afraid to put yourself out there, it means the world to us, because we're being heard and we're being validated, and it is a priceless gift in our community. So thank you for what you do.
Thank you. But it's one patient at a time. I started with my patient doing what she wanted me to do to get better.
Yeah.
And I see everybody getting better. It's a no-brainer. I trust my patients. I believe my patients first.
Absolutely. Thank you so much.
You are welcome. Thank you. I'm glad you feel better.
Thank you.